Hello everyone, my name is Alina Fillon and I will be presenting on the sterility practices in interventional radiology. I will be talking about the sterility practices at Swedish Medical Center, things I have observed, the need for improvement, and the changes that were made in response to those needs. To begin, we should start with what is interventional radiology. Interventional radiology is a procedural area that includes minimally invasive surgical procedures which are image-guided, usually using ultrasound, X-ray, or CT. The most common one of them is X-ray. Some examples of procedures that are seen in IR include portacath placements, which are catheters inserted into the chest with a catheter that follows into the heart for chemotherapy infusions or blood draws, which is an easier option also for those who have difficult IV access. Additionally, when people have GI issues such as bleeds or liver cancers, and other problems in abdominal areas, IR treats those issues using embolizing materials, which are bleed-stopping materials, or chemotherapy infusions that target tumors in the liver. Other procedures include abscess drain placements, nephrostomy tube placements, and much more. These procedures require sterility to prevent infections. Even a minor lapse in technique can create further complications in patients that will harm them instead of helping them get better. To give some more background, I worked at Swedish Medical Center IR for about a year. During my time at Swedish Medical Center, there were a few actions that I observed that helped me to notice there was a lack in understanding of proper sterility guidelines. Everyone was following different rules by stating what they thought was right, though everyone knew the rules, but some had different translations of them, and everyone came from different backgrounds of working in the sterile environment. There was often miscommunication and confusions about the standards, and the goal in this project was to go back to the basics, align with the policy, and create the changes that are needed. IR is an important factor in managing infections, and it would be very unfortunate if it was the cause of some of the infections. As the quote by Hines and others state, infections seen in IR can be found in two main scenarios: as an indication for percutaneous drainage tube insertion, such as the presence of a sizable abscess, cholangitis, combined urosepsis and hydronephrosis, and empyema. This is what I mentioned in regards to abscess drain placements. Or as a complication of an IR procedure, such as infection occurring after an IR procedure. Though infections are not significantly common after IR procedures, they are still possible. Hospital-acquired infections, also known as nosocomial infections, are a common occurrence in healthcare settings. Oftentimes, because patients receive treatments from all over the hospital, it is hard to fully track down where the infection originated. Although there were no specific cases of infection from Swedish's IR department, there had been cases of vancomycin-resistant enterococci, which is VRE, at another IR location. VRE is generally an infection that is commonly acquired in hospital settings. Vancomycin is a drug that is used to treat different bacterial infections, and if the patient becomes resistant to them, that becomes a big issue. In the article by Setterman and others, it stated that neither technician performed hand hygiene before preparation, nor did they don gloves or other personal protective equipment during preparation. They also added that a previously unrecognized VRE outbreak related to IR procedures with contrast. Their investigation strongly suggested that the use of non-sterile technique during invasive IR procedures was responsible for the outbreak. We also often receive patients that come back to have their pore or other central lines removed for bacteremia. An article by Kozlowski and others states that double lumen chest boards are associated with increased risk for bloodstream infection, malfunction, fibrin sheath formation, catheter tip malposition, and catheter-associated thrombosis. Bloodstream infections are a big deal. However, it is hard to track down who is truly at fault. Everyone in the hospital will use those catheters, and if they're not properly inserted, cleaned, and used, it can lead to bloodstream infections. Bloodstream infections can further lead to further infections in the body and sepsis. Since we use bloodstream for all arterial and venous access, it is important to make sure that there is proper sterile technique followed and that everyone is on the same page. There were a few problems I was able to identify when trying to conclude on what issues there could be in our department when we discussed the problem of sterility in the IR department. The first one was there was often times staff found that was not wearing sterile attire. We have environmental services that would come through and clean every room between procedures. They would sometimes come without sterile caps, masks, and improper sterile environment attire. Additionally, staff from other departments would often forget and not put proper attire on. Although there were not currently open sterile materials or a sterile patient on the table, this stood in the way of making sure that the rooms were kept clean and free from harmful airborne bacteria. There was also no proper hand wash instructions placed by the sinks. This can cause some confusion between staff on what is proper sterile hand washing and what steps need to be taken between every procedure. There were also gaps between the training that was received between staff. Some staff have been there for multiple decades, and others might not have been there for long, but policies tend to change throughout the years, and mandatory meetings and trainings are important for policy updates. We also noticed an issue with the sterile packs. These sterile packs would come with gowns that are placed inside the sterile pack. When the technologist would come into the room after proper scrubbing, they would grab the gown off the table. When we discussed the matter with the surgical services management, it was found that there is a high chance of contaminating the sterile field when reaching over the table. Thus, we found this was another area for change. To start off, we hosted a staff meeting to go over the policies and make sure everyone was on the same page about the policies in place for a sterile environment. One of the first things we did was create a hand washing station sign to create a visual for everyone in the department about the rules that are in place to help infection prevention. There were two options for sterile hand washing. One using a sterile scrub sponge, which contains chlorhexidine for full cleaning of the hands, and an Avogard solution, which is another alcohol-based solution, to help clean the hands properly. Another tool we used was creating a red line alerting sign for everyone that comes into the department, so they could see the expectations that they're measured to when they're in the sterile area. Another action we took was using a separate package of gowns and gloves on a separate table to prevent contamination of the sterile cart. We also contacted the makers of the sterile packs to change the packs to include a separately packed gown to conserve space and to also serve as a reminder. As you can see on the right, the packs would typically come with unpacked gowns, one for the technologist and the other for the doctor. This may seem like a small change, but in a high-pressure environment, even small changes can make a significant improvement. While the packaging given by the manufacturer was functional, it served as a chance for error and contamination. Although we could not fully see the effect of the changes we took towards infection control measures, we were able to see a greater engagement with staff. People understood the importance of why we do what we do and how we can better prevent instances in the future of possible contamination instances. When people understand the importance of reasoning behind sterile practices, they're far more likely to adopt these practices with greater consistency. From hand hygiene to proper gowning and gloving, there's a great contribution to the presentation of infections and the overall safety of the patients in our care. The change in their mindset is the greatest driver in ensuring the changes are lasting. When people feel supported and informed, they're likely to carry out their mission with a sense of purpose. The future of the patients is in our hands, and patient safety is an important aspect of every area in the hospital. And it is important to recognize that it's not just a one-time goal. It's a continuous improvement that attributes to every area of the hospital. This includes maintaining the highest standards of infection control, especially in areas where patients can be at most risk. The patients we get in our department are very sick, and they're there for help. To continue to keep these changes effective, we will continue to analyze the important aspects of what can stand in the way of infection prevention controls. It is important to conduct meetings that will continue to reiterate the importance of an effective, sterile, and clean environment. Although these are some of the things that people should know and may have known previously, but over time, the busyness of an area can get people carried away with other things. It is important to continue to follow these measures to ensure safety of our patients. The goal is to make these practices a greater standard that they reflect our workplace without the need for constant reminders. Maintaining a clean environment is not just for the check mark of the policies, but it is about safeguarding the future of our patients. The purpose of this report was to create an evaluation of the changes made within the IR department to increase sterility and patient safety for infection prevention control. These changes were made to increase the greatest compliances with the standards and infection. There are a few courses that allowed me to understand the significance of this area better. The first was intercultural health communication, which helped me to communicate with a diverse team of professionals and to gather feedback from staff to create surveys of the changes that they thought would benefit our department. This also allowed me to help conduct meetings and to help communicate better with the team. Additionally, economics of healthcare and biomedical ethics both served as resources to better understand infections and the impact of them on the workplace. Hospital-acquired infections can increase operational costs and create a greater strain on the resources. Additionally, patient trust and safety can both be significantly compromised when we fail to do what we need to do. Swedish Medical Center and Department of Health served as great resources for what is expected in the workplace and what policies are important in making sure that patients get the care they deserve. And these are my references. Thank you, everyone.